Hi, this is Alvaro Alonso, Assistant Professor of Medicine at the University of Massachusetts Medical School. I would like to thank Dr. Craig Walker for the opportunity to participate in this New Cardiovascular Horizons Organization digital education series. I will talk about mesenteric artery stenting, when and how. So first of all, let's review a little bit of the mesenteric anatomy. So the mesenteric or splenic vessels include the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery and their branches. So right at the level of T12 to L1, just below the diaphragm is where the celiac artery arises. And this then bifurcates into splenic and the hepatic. Those actually provide collateral networks with this SMA. Approximately 2 centimeters below is the origin of the superior mesenteric artery, or SMA. That supplies mostly, the small bowel. There are multiple mesenteric collaterals and also anastomos with inferior mesenteric artery. The IMA arises approximately at the level of L2, L3, approximately 3 centimeters above the aortic bifurcation, and it's a much smaller artery in terms of caliber, but also provides significant blood flow to the sigmoid and other arteries. So these collaterals could be very important whenever there is actually a stenosis. So we have some fancy names, like the meandering artery of Moscovitz, also known as the arc of Ryland, which connects the SMA with the IMA, as depicted in this CAT scan and in this angiogram, or the marginal artery of Drummond, which connects the other way around. But those are interesting findings and could be relevant in trying to determine the chronicity of the patient's presentation. So mesenteric ischemia is caused when there is an imbalance between the supply and the demand for nutrients and oxygen in the mesenteric circulation. Most frequently, we will talk about atherosclerosis as being a cause of typically chronic mesenteric ischemia, but you could also have arterial emboli, dissection, which tend to cause acute thrombose, acute mesenteric ischemia, arterial in situ or venous thrombosis, or vasculitis. There is also mesenteric venous thrombosis. And in patients with very low cardiac outputs, they could also have non-obstructive mesenteric ischemia. There are other conditions such as celiac artery compression syndrome or inflammatory or other conditions that could also affect the mesenteric circulation in general. Mesenteric ischemia is infrequent. The true prevalence is not completely known. We know that of patients that present to the hospital with abdominal pain, less than 1 in 1,000 are related to mesenteric ischemia. Now, many of those may be acute mesenteric ischemias, although I have also seen patients with chronic mesenteric ischemia presenting to the hospital as presentation. Many with chronic mesenteric ischemia could also be evaluated as outpatients. So the important point is to distinguish between acute and chronic, because acute mesenteric ischemia, typically severe abdominal pain that is described as out of proportion to the physical exam findings, is associated with a high morbidity and mortality. Arterial embolism is responsible for approximately half the cases, but you could also have plaque rupture in pre-existing atherosclerotic plaques, and those account for approximately 35% of cases. Dissections and other things are miscellaneous etiologies of acute mesenteric ischemia. The diagnosis of acute mesenteric ischemia, you could see alterations in electrolytes, elevation in lactate, metabolic acidemia, and CAT scanning would show, the CT angiography would show potentially the actual anomaly, but you could also find other findings that are suggestive of mesenteric ischemia, such as bowel thickening or even perforation and free air. Chronic mesenteric ischemia, which is really the main topic of this talk, it tends to be caused by progressive atherosclerosis in greater than 90% of cases. There could be other etiologies, but the majority of them are atherosclerotic. So, patients with atherosclerosis tend to have the risk factors for atherosclerosis, diabetes, hypertension, etc. What are the non-atherosclerotic etiologies? Well, you can actually have patients with fibromuscular dysplasia that affects the splachnic vessels. There is celiac artery compression syndrome, which is a disorder in which the pillars of the diaphragm compress the celiac artery and actually gets affected with inspiration and expiration. Patients with neurofibromatosis may also have mesenteric ischemia. People who have mid-aortic syndrome, which is a diffuse stenosis of the mid-aorta. Patients with radiation injury can develop stenosis of the aorta or its other vessels, or patients with vasculitis. And all of these can have also chronic mesenteric ischemia. Most of the patients with chronic mesenteric ischemia have an age that exceeds 60 years of age. Chronic mesenteric ischemia is 3 times more frequent in women, and about half the patients will have polyvascular disease. This is coronary or lower extremity or carotid artery disease. Patients with chronic mesenteric ischemia will typically develop postprandial discomfort or pain that can happen anywhere between 15 minutes and 30 minutes after eating. Oftentimes, the pain will be so severe that the patients will be afraid of eating. We call that cetophobia. But it can also present with very atypical symptoms, such as nausea and diarrhea that is otherwise unexplained. And patients may develop weight loss, either from being afraid of eating or diarrhea. I think that distinguishes that from other conditions as well. Now, when patients have celiac stenosis, they can also experience atypical presentation. So they may present with gastroparesis or gastric ulcerations that are of ischemic origin, or also gallbladder dyskinesia. Unfortunately, this is very vague in the majority of patients, and so the suspicion should be high, particularly in people all over the age of 60 with multiple cardiovascular risk factors. It is unfortunate that the presence of abdominal bruit is only in less than 50% of these patients. You could evaluate these patients with duplex ultrasound, computer tomography, or magnetic resonance angiography. Duplex is a cheap and readily available technique that will allow you to diagnose if the views are adequate. And this could be a problem in people with morbid obesity or people in the non-postprandial state. Duplex criteria includes a peak systolic velocity of greater than 200 centimeters per second. You could add end-diastolic criteria to increase the specificity. Or in the celiac artery, a peak systolic velocity that exceeds 275 centimeters per second, as depicted here. So there is the origin of the SMA, there is a color aliasing, and there's a spectral Doppler waveform that actually is exceeds this 400 centimeters per second there. The sensitivity and specificity of duplex is very high. It approximates 90%, so it's very good. Computer tomography angiography has an even greater accuracy. Vessel reconstruction and additional bowel findings could be useful at identifying or features, or trying to differentiate acute versus chronic mesenteric ischemia. The reconstruction of the vessels could also help you understand what is going on and actually help you plan for your procedure. MRA also has about a 90% accuracy. It tends to overestimate the degree of stenosis. This is a known problem with MRA in general, but you could actually utilize it in specific subsets. For example, an MRA without gadolinium with time of flight technique could be used to do a scan in a patient with chronic kidney disease without gadolinium, obviously, and that could actually give you the information that you need. Once we have made the diagnosis and our patient is symptomatic, then we need to decide how to treat it. And there are two essential treatments. One is endovascular, and the other one is surgical. Both have a class 1 indication according to the ACC/AHA guidelines. So endovascular treatments include angioplasty alone, which tends to be to experience subsequent restenosis. The other one is stenting, whether with a bare metal stent or cover stents. Complications are reported to be less than 10% with endovascular techniques, and the most frequent vascular complications actually tend to be vascular access complications rather than mesenteric themselves, although dissection and embolization could certainly occur and could be catastrophic. It is recommended that when someone does endovascular approaches, that there is either surgical backup or some sort of plan to transfer these patients should they require a surgical intervention as a bailout. Surgery includes endarterectomy or bypass grafting. The perioperative mortality has been described as high as 17% in some older series. Is now much lower mortality, approximately 3 to 5%, but is a much more involved procedure regardless. So the risk of complications is still as high as 15 to 30%. A comparison of series of outcomes of intervention in chronic mesenteric ischemia shows the advantages and disadvantages of both techniques. So the technical success tends to be very high in both subsets, surgical versus endovascular repair. Most patients achieve initial symptom relief. The mortality tends to be lower with endovascular approaches, as has been discussed. In these areas, they report a 5% in some of the studies. But the vascular approach may lead to further procedures where there's lower patency than with bypass grafting. And so individual decisions may come. Many times these patients are at very high surgical risk. So no matter what, the best approach would be endovascular. And this highlights the importance of continued surveillance of these patients. Well, let's get to the procedure. So I think the most important point is to really review your clinical information and your clinical studies. The duplex, the CTA, the MRA, because that will help you decide which access site you're going to try to use, whether femoral or radial or even brachial, depending on what the anatomy looks like, what the angulation of the takeoff of these vessels is, etc. I think that if people venture into doing transradial or transbrachial procedures, it's important that you review and ensure that you have stents and balloons with a shaft length and sizes that you will require to do that. I have seen people realize in the middle of the procedure that they don't have the balloon length that they require, or the stent or the sheath. And so it's important to plan everything. These procedures are not emergencies typically. And so you can plan and request that you have everything that you need. Intraprocedurally, I typically start with a PA view as a general comparison in case there is distal embolization, but the lateral views will be essential to actually be able to visualize the ostia of the celiac or the SMAs. Some people recommend doing oblique views. I don't necessarily always do them, but definitely a lateral view is going to be your essential view because, you know, to deploy the stents. Oftentimes we utilize carbon dioxide as to get a lay of the land, and then eventually get selective into the vessels to perform angiography with selective catheters. There are multiple catheters that are pre-shaped that you could utilize, which are listed here: the Cobra, the Siemens, the SOS, visceral, selective one, etc. If you have a question about the severity of the stenosis, or maybe the patient doesn't quite fit all the criteria, you may want to consider measuring pressure gradients. And if you do that, less than a 15, you should exceed 15 millimeters mercury with a 4 French catheter or less to consider as significant. That's a peak-to-peak pressure gradient. Many times, if this is an initial evaluation, we may go transradial with catheters and then utilize pressure wires to measure the gradient, and that is much less invasive. And then if the decision is to proceed with the intervention, all these patients need to have anticoagulation aspirin, and most of us would use clopidogrel with a loading dose in a cath lab, and continue for 1 to 3 months. There are multiple pre-shaped sheaths that could be utilized. You could also utilize telescoping techniques, particularly if you're approaching these from an arm approach, whether brachial or radial. And so having a supportive sheath and then eventually a catheter that will allow you to direct into the vessel, and then advance your wires and things like that could be very helpful. Operators use anything from a 14,000 of an inch to a 35,000 of an inch platform. It doesn't really matter as long as you have supportive equipment and supportive wires that will allow you to deliver your equipment. Some people stay away from pre-dilating the vessels as an attempt to minimize embolization. I think that if you're going to use a covered stent, you should always pre-dilate, because covered stents are known to potentially get dislodged and then get you in a binding. If it's a direct stent with an open cell stent, you could probably obviate the pre-dilation. But again, it all depends on how tight is the stenosis, and sometimes you need to even do serial dilations with 1.5 millimeter balloons and grow your lumen until you're able to deliver your stent. Typically, stents are between 6 to 8 millimeters. You need to ensure that you're covering the ostium. Some people use the ostium placing devices as well. Some people use also embolic protection. Again, there's not much data. It's like in the renal literature. But it has definitely been utilized, and it could be valid. Covered stents have recently been shown to have lower rates of restenosis. So this is actually a large retrospective series, including Mayo and I believe Arkansas patients. They put their databases together, and covered patients who underwent covered stent for the SMA had a much greater freedom from recurrence as compared to open cell bare metal stents, and the freedom from reintervention was approximately 90% with covered stents versus 54% in patients with bare metal stents. So it's not randomized data. Randomized data will hopefully come by the Kobaji trial, which was published last year. The product was published last year, and we'll begin enrolling hopefully soon. The long-term management of these patients is not very complicated. Most of these patients will be on aspirin for lifetime. Most operators will do clopidogrel for 1 to 3 months. We don't have randomized data, but it's an extrapolation of what is done in other vascular territories. We don't have specific data with regards to low-dose rivaroxaban in patients with mesenteric ischemia, so we cannot really give a recommendation about that. And it's just very aggressive cardiovascular risk factor modification. During the first year, patients should have a baseline or a new baseline, and then a duplex every 6 months for that first year. And then the duplex should be repeated every year. People should understand that velocities in duplex studies in patients who have received stents tend to be much higher, so they would look like they're stenosed. So you really have to analyze your images and see whether there's color aliasing, what the morphology of the waveforms could be downstream. Some studies have suggested a cutoff of approximately 445 centimeters per second as a cutoff for significant risk stenosis, but you also follow your patients clinically. What to do about patients who have multi-level disease? I mean, it's thought that you need to have 2 of the 3 vessels compromised to cause mesenteric ischemia, but that's not always the case. Having said that, patients may oftentimes have this, and it has been shown that stenting all the involved vessels actually leads to lower rates of clinical recurrence than stenting only one of them. So in conclusion, chronic mesenteric ischemia is often underdiagnosed, and it causes chronic gastrointestinal symptoms that we discussed. Percutaneous vascular intervention achieves a high success rates and requires monitoring for restenosis. Covered stents might decrease restenosis rates, and surgical treatment could be an option in selected patients. Thank you so much.